There you go. So we're going to quickly go over the soleus and the plantaris muscles, kind of everything you need to do to know about these muscles. So we're going to look at, first we're going to look at the soleus muscle trigger points and referred pain. Where the soleus muscle has, as you can see, three main trigger points. The first trigger point is located about 2 to 3 centimeters distal to the gastrocnemius belly and slightly medial, so on the inside, right in here. And the referral is posterior heel, plantar surface, and distal Achilles tendon. So this gives you that Achilles tendon, even potentially some plantar fasciitis symptoms. So you always want to look at this trigger point anytime you're having a patient with any Achilles tendonitis issues or plantar fasciitis. Trigger point 2 is located high on the lateral calf, right up in here, and it's diffuse calf pain. This can also sometimes even cause some knee pain, and especially patients that are usually loading their feet on the lateral aspect, a lot of them are going to have this trigger point. And trigger point 3 is a rare trigger point, proximal and lateral to trigger point 1. It's deep pain in the ipsilateral sacroiliac joint, so it's the referral is right up in here. So that's quite and then spillover can also be going into the heel. So this is a rare trigger point, but it can happen. So you always want to kind of look for that pattern. Trigger point number 3, jaw pain. It's an unusual referral, but it can happen rarely as well. And on a clinical note, soleus trigger points do not cause calf cramps, unlike the gastrocnemius. So if people are having calf cramps, then most of the time it's the gastrocs. Here's the plantaris muscle, the small muscle. The referral pattern is right behind the knee, down posterior calf, kind of mid-leg. Occasionally, it can also go down to the ball of the foot, base of the big toe. So we always want to try and look at these structures as well. A foot referral may stem from plantaris or lateral gastrocnemius fibers. The source is uncertain. Clinical relevance: important to differentiate the source of referral for accurate treatment. Consider overlap with the gastrocnemius trigger points. The reason why this guy is similar to the gastrocnemius, obviously, because it goes across the knee joint. Here is the soleus muscle, anatomical attachments. As you can see, it's very important in the ankle joint. So that's where the Achilles tendonitis, as well as the plantar fasciitis, the soleus, can have a big impact on that. It does not cross the knee. The proximal attachments is posterior head and proximal third of the fibula, so it goes all the way up into the fibula. So this is why it's very, very important. Often we kind of get a sense that the soleus attaches a little bit lower, but it goes all the way on the lateral aspect, all the way up to the third of the fibula. Middle third border, tendinous arch. This is basically the soleus canal. So that's where the important structures such as tibial nerve and the vascular structures go through. Distal attachments, underside of the Achilles tendon. It's the medial third of the calcaneus. So this is why it's very important. So sometimes you get someone with Achilles tendonitis and they show more symptoms on the inside. Well, then right away you know that it's most likely going to be the soleus muscle versus the gastrocnemius, the lateral 2/3. So the soleus is medial third, whereas the gastrocnemius is lateral 2/3. Encased by tough fascia, so basically forms a soleus bridge. Deep fascia fuses to medial tibial border, and this is where we talked about may compress neurovascular bundle proximal to the scoliosis canal. So this is where basically that compression can occur in that area. So that's what you kind of got to watch out for, and you got to palpate and see how this area is. As you know, the soleus muscle is mostly slow twitch fibers, type 1, whereas the gastrocs is more fast twitch fibers. So this is why soleus muscle is kind of like the grunt, or when it comes to long distance running, any sort of running, the soleus muscle takes a lot of the force. Plantaris is a very small muscle, as you can see, often considered accessory muscle to the lateral head of the gastrocs. It's absent in 6.2 to 75% of the limbs. Proximal attachment, lateral femur, originates lateral elongation of the ana aspera, and the muscle belly crosses the popliteal space. So this is where it's important when you're palpating the popliteal space. You could be palpating the plantaris as well a lot of times. And it's deep to the lateral gastrocnemius. Anything. Sometimes implicated in knee pain and calf pain referred patterns. So you always want to look at this muscle when it comes to knee and calf pain. It's variable in origin, structure, as well as insertion. When it comes to the gait cycle, opposite toe off. So basically when the other leg pushes off the ground, at that moment your soleus on the standing leg becomes to activate. So this helps control the ankle and the knee as your body weight shifts forward over the standing leg. Heel strike when the other foot lands again, so your soleus muscle stays active until the opposite heel touches down. This marks the end of the primary stabilizing role of the stride. Soleus is responsible for resisting forward tibial motion. It provides knee and ankle stability, energy conservation. So it's a very, very important muscle when it comes to gait. Muscle action, so lengthening contraction and early stance and shortening later. So if you can imagine, he's getting into that dorsiflexion. That's when it lengthening contraction. So it acts independently of the knee angle and assists, because it doesn't cross the knee joint, assists in inversion and medial via medial Achilles tendon attachment. So rather than being attached on the outside, it's attached on the inside. So therefore, it's responsible for assisting with inversion. When it comes to walking, primary role is knee stability during stance. So that's why someone that has knee pain, it's very important to look at the soleus. Bicycling, it's increased in toe position. So basically when they're pushing through their toe, that's when it's increased. When it comes to functional subdivisions, medial soleus is power and stabilization, whereas lateral soleus is stabilization on unstable surfaces. So as we mentioned, it's soleus is a slow twitch fiber, which means that it's fatigue resistant. So it's very when it comes to fatigue, it doesn't fatigue as soon as the gastroc. Contraction time is obviously going to be slower because of the fact that it's slow twitch fibers. High mitochondrial cytochrome C oxidase activity. As we discussed, the medial activation is with inversion, and lateral soleus is more eversion. Minimal blood flow interruption even at 80% maximal contraction. The reason why that is because it needs constant blood flow. So when it comes to the venous pump function, contraction expels blood from the venous sinuses in soleus. So you can see soleus is the prime muscle when it comes to venous pump function. So when they say muscle pump, soleus is the main muscle. Clinical relevance prevents venous pooling, effective in Trendelenburg position or passive dorsiflexion. So calf pump is more effective than thigh pump for venous return. So as we discussed, it's a very, very important muscle when it comes to venous return of the blood from the leg. So here are some symptoms that are related to the Soleus and Plantaris trigger points. Common symptoms, Soleus and Plantaris trigger points is, so as we discussed, heel pain worsens with walking, stairs, and limits dorsiflexion. So when someone is coming into you for heel pain, that's when we got to look at the soleus muscle. Trigger points 2 and 3 are mostly calf pain, possible referred to SI joint or even the jaw. Plantaris trigger points is mostly pain behind the knee. Difficulty, functional impact, difficulty arising from sitting, walking uphill, lifting objects with proper form. Differential diagnosis and related conditions. Achilles tendonitis, so basically these are all kind of commingled, where the trigger points of the soleus muscle can be implicated within the Achilles tendonitis. S1 radiculopathy, DVT, these are all differential diagnoses and related conditions. And then popliteal Baker cyst, so that all can be implicated, for example, even when it comes to Plantaris. Heel spur, pain, Hoglin's deformity, which is shown right here, and posterior compartment syndrome. As we've discussed, so heel pain, especially when placing weight on the heel or at night. So this can be confused with plantar fasciitis. Restricted anti-dorsiflexion, so it's ankle dorsiflexion, so this is something that we need to check. When the dorsiflexion is limited, this leads to poor lifting mechanics, potential low back pain. Functional impact, difficulty raising from chair without armrest, pain while walking uphill or climbing stairs, pain worsens with prolonged standing or exercise, so this is important. And recreational runners often report soleus-related heel pain. So this is when your recreational runner comes in, it's very important to look at the soleus trigger points. When it comes to the Plantaris trigger points, often refers back of the knee and upper calf. Pains aggravated by walking or running, especially after starting a new training program. So these are exercise-related syndromes specifically. So we have shin splints. People come in a lot of times with shin splints. There's medial, there's posterior anterior shin splints. So this is basically talking about medial tibial stress syndrome. This is similar to your posterior shin splints. Caused by repetitive loading at the soleus tibia insertion. So if you can imagine that insertion of the soleus along the tibia, that soleus, if it's inflamed, it's going to cause irritation onto the tibial bone and give you that medial stress. So basically giving you that tibial stress syndrome, that kind of bone pain where you press and the bone hurts. Pain begins late in exercise, persists even post-exercise. That's when people kind of feel it the most. Tenderness, posterior medial tibia. Other clinicals, so we discussed Achilles tendonitis, may stem from tightness in these muscles. Heel spur pain may actually be referred soleus trigger point, not the spur itself. And trigger points in the foot muscles. Quadratus plantae, abductor hallucis can mimic the heel pain. So when it comes to plantar fasciitis or any sort of heel spur pain, it's very important to check off these muscles rather than telling the patient that it's because of the heel spur. Activation of the trigger points. Primary causes: foot slipping at toe off. So when it's wet or slick surfaces, when that foot slips, that's when you might activate the trigger point. Forceful lengthening contractions, jogging downhill or slipping, direct trauma or cold exposure, lower limb length discrepancy. There's more stress on the shorter leg. Common overload scenarios: walking with smooth soles on hard floors, jogging with forefoot landing, that provides vigorous eccentric contraction, skiing, ice skating without proper ankle support, prolonged or unaccustomed activities, such as hiking uphill, walking on slanted surfaces. So, for example, walking on beaches. Those are all the things that might trigger these trigger points. Other mechanical triggers: slipping on stairs, overload on stance leg soleus, sustained pressure, wearing inflexible shoes. Satellite trigger points also from the gluteus minimus can cause that as well. And then long chilling of tired legs, long car trips with the AC on. So perpetuating factors for these trigger points is, let's say, if the soleus muscle is kept in shortened position for too long. So for example, wearing heels, that means that the ankles in plantar flexion for a prolonged period. Thick heel lifts on one side, sleeping with ankles plantar flexed. This is an issue I find because of the fact that I have a heavy I have a heavy blanket that I use. This probably doesn't help because my feet are always in plantar flexion. So that could be causing potentially some of my calf issues as well. Sitting on chairs that are too high, feet are not flat. This is, for example, can be someone that's sitting at a desk for too long. Legs resting on chair edges, ottomans or dental footrests, tight socks acting as tourniquets. So this is very important because this kind of cuts into the back of the leg and causes issues for sure. Persistent postural footwear habits can activate and maintain trigger points. Blood flow restriction, mechanical stress, shortened muscle positions are major perpetuators of these trigger points. Managing these soleus trigger points requires underlying biomechanical and circulatory factors. Soleus muscle entrapment. So tibial nerve and posterior tibial vessels pass through the soleus canal, which you can see is right there. And if the soleus muscle does have trigger points around that area, that can cause issues for sure. It can give you nerve type issues or even circulatory issues. Leg extended, compression triggers, leg extended and foot dorsiflexed. Swelling, a fibrous band of the soleus trigger points causing localized compression. Symptoms: foot and ankle edema, heel pain, tingling at the lateral foot, relief, inactivation of deep soleus trigger points, or surgical. You can also get a surgical arch release. Plantaris muscle entrapment, popliteal artery entrapment by the plantaris tendon reported in young athletes with misdiagnosed shin splints. So if anyone has these shin splints type issues, you gotta go and look at the plantaris because that guy runs kind of this way. Corrective posture for soleus trigger points: avoid sleeping with ankles in plantar flexion, maintain neutral, pillow furniture support under the sheets, hanging feet off the bed when prone, that can help. Avoid excessive hip or knee flexion in bed, use small pillow under the knees, use flexible non-slip shoes, stiff soles overload the soleus. Avoid high heels and heel lifts that keep soleus in a shortened position. Sitting and leg rest modifications: ensure feet rest flat on the floor. If seat is high, use a cone-shaped footrest. Avoid under thigh compression, so tight chair fronts. Optimize leg rests and use a slanted footrest to maintain 90 degrees of ankle angle.